Today, we have a very special episode discussing multidisciplinary approach to treatment of spinal tumors with doctors Mark Amsbaugh and doctors Lador. Why don't we start off with telling us where you guys are at, what your practice looks like, and how does it differ from others in your field with regards to spine tumors and spinal pathology? We'll start first with you, Ran.
Both Mark and I work at University of Texas, Memorial Hermann in Houston, and we set up a goal of establishing and creating a cohesive multidisciplinary tumor program in Houston. We have a huge referral center and a base of patients, obviously needing and unfortunately suffering from spine tumors. And getting treatment in a very cohesive way was a challenge. And so we worked real hard in the past several years to create a program where we join forces and treat those patients. The nice thing about it is we found a friend and we are working together, and it's actually fun. We tease each other, we fight each other, we arm wrestle. I always lose, but it's still a fun thing to do.
And what about you, Mark? How does your practice look and differ from others? And as Rand was saying, why a spinal tumor board?
I think Rand kind of hit it on the head. I think both of our practices are somewhat unique in the country, and I think that starts with both our academic affiliation with University of Texas McGovern. It's a very large medical school here in Houston, which is the third largest city in the country. So the breadth and depth of pathology that comes in because of the academic affiliation with the school is quite large. But in addition to that, we both primarily practice at Memorial Hermann in the Texas Medical Center, which is a quaternary care large referral hospital for both regional, national, and international patients to come in. So I think the number of patients that are seen with varying pathology is quite great. And in addition to working together, we also have the opportunity to work with many very talented, very subspecialized colleagues who are really the best at what they do in the country. So it's been really great to not only have the opportunity to care for such a broad range of patients, but also have, kind of a high number of unique cases that allow us to have experience with really tough things and share the treatment of those patients with truly fantastic colleagues. So I think it's a little bit of the academic mix, a little bit of the regional and international referral mix from the Memorial Hermann system that makes our practice pattern somewhat unique. So to kind of say why spine, spine tumor boards tend to be very rare throughout the country. Many institutions may have a general tumor board, which, has become more and more common when caring for oncology-related patients. But in many general tumor boards, patients with metastatic spine tumors or primary spine tumors are not even presented. I think there's even a smaller group of CNS or neuro-focused tumor boards throughout the country. Many institutions have those, as well as certainly tertiary or academic referral centers that deal with cancer patients. But even within those tumor boards, it's very rare to discuss cases that affect primarily the spinal column, whether those are primary or metastatic patients. So I think one of the unique things, just given the volume that's seen within the Memorial Hermann system and the unique challenges of patients who may live hundreds, if not thousands of miles from the hospital where they're receiving their care, prompted us to get all the interesting parties together to really kind of move forward with how we care for spine patients, both at the Memorial Hermann and Texas Medical Center, but also across the country. We want a lot of what we do to impact spine care, everywhere. And that's partially through our tumor board. It's partially through great organizations like STS, which Ran is a founding member of. But we're looking to advance the care for these patients, which I think lags a little bit behind other diseases.
And I think you hit the nail on the head too with multidisciplinary approach. You mentioned that people who are listening to this didn't see me pointing to myself, because I had the pleasure of working with both of these two fantastic colleagues for many years when I was at UT and went out, interventional radiology, rad-onc, surgery, oncology, very important to treat and manage these patients. And while talking about that, these are very difficult tumors to manage. And so being where I am now, it's managed sometimes by general orthopedic surgeons, sometimes by neurosurgeons. But Ran, you do something a little bit different. And can you tell us a little bit about what's different and what your subspecialization does for these patients?
I think that taking care of patients with tumors or with cancer is not the same. Unlike what the typical notion of a surgeon, where you have a problem, you fix it, and you forget about the patient. If the patient can sleep during this process, it's even better. Oncology is not the same. The patient comes with a
It's not,
baggage.
it's broke, we fix it, we're good.
Exactly.
Okay.
And the patient come with a baggage of problems. And to echo a little bit what Mark was alluding to, is our multidisciplinary approach we put the patient in the center. And it's not just a phrase. The patient is in the center. There's so many other things that are involved in managing the care of the patient. And as you were saying, we have so many subspecialties. Just navigating between those different things, the process of taking care of a tumor, starting from diagnosis, getting the biopsy, understanding what that means, connecting with medical oncology, then planning a surgery, what type of surgery if needed, and then radiation. Just navigating this process is so overwhelming to the patient. And so we actually have a navigator that helps us with that, and a phenomenal person that actually takes the patient by their hand and then goes through all this process. I think that surgically speaking, taking care of spine tumor, you can be a surgeon that takes care of oncology, or you can be an oncologist that take care of spine problems. And that's a huge difference. And I think that we try now to be more of an oncologist taking care of spine problems rather than a surgeon then is fixing a tumor or fixing a problem in the spine. And the difference is the mindset. We're thinking of not only how to make or manage the here and now problem, how do we allow Dr. Amsbaugh to deliver the best treatment that is possible? How do we allow our medical oncologist colleagues to deliver everything we can? How do we coordinate all of those things? And it requires understanding the tumor, understanding the needs of the radiation oncologist, the needs of the medical systemic treatment. How do we utilize interventional radiology? How can that help? How can we make them work with us and for the patient? It requires a constant learning and constant development and communication, which is unique, I think, within our group.
And I can imagine that the surgeries you do greatly affect the timing of radiation as well as giving chemotherapeutics because of time to heal. And so doesn't it take like 6 to 8 weeks to heal from surgery?
I love that question. It's just the biggest passion. And you were kind of asking before, what are we doing different? And we use our other, baggage of expertise to take care of tumors. And the fact that we do take care of other spine problems in a minimally invasive fashion allows us to take care of tumors maybe in a similar fashion. So in the past, we used to do huge surgeries that would delay the treatment of the systemic treatment, the chemotherapy, the immunotherapy, and the radiation. We now are able to use minimal invasive techniques, various techniques, with endoscopic surgery, with the tubes, with microscopes, with ablation options, to allow a more condensed treatment where we do an intervention, but we start the systemic treatment as soon as possible. And so often we are able to restart or take care of the whole disease way earlier and sooner by using different techniques that were used in the past. And I'm very happy that we are at the leading edge of that these days.
Yeah, some of your surgical techniques, if I remember right, they can restart within, at times, 3 weeks, restart chemo, correct?
I think our record now is 4 days. We were treating with minimally invasive tumor separation surgery using a very small incision. And we got the patient to start radiation 4 days after the surgery, including systemic treatment. That's a game changer in my mind.
No, it's massive because it allows for everybody to participate in the care of the patient to actually be getting the best of everybody in the field in a timely fashion, where in the past, I think there were barriers due to healing time, or time, for counts to come back as well. So this is really incredible. For people who are starting up, spinal tumors, how do these referrals happen? Do they come directly to rad-onc? I would imagine a lot of metastatic disease would go directly to rad-onc. Do they come to surgery? And what are your first steps in workup?
Yeah, I would say that that's a great question, Alexa. I mean, the part of the reason for the multidisciplinary approach, part of the reason for needing a navigator throughout this process, and one of the things that we think makes the program at Memorial Hermann special is that these patients come from everywhere. It is not a single referral chain into the program because spinal tumors are so common in metastatic disease that they really affect patients, and the impact on patients is so varied. So there are patients with asymptomatic spinal tumors that may be detected on routine imaging that's being done by a medical oncologist or a radiation oncologist during the course of a workup. There are patients who have profound neurologic impact of spinal tumors that may not even know they have cancer yet. It may be the diagnostic presenting symptoms. So you can imagine that the needs and, ultimately referral chains for these patients, who we need to get involved from a physician standpoint, from a supportive care standpoint, from a physical medicine and rehabilitation standpoint, are quite different amongst these patients. So I think, that's one of the things that makes the care of spine tumors so complex. And I think it's been one of the challenges, honestly, in the field of spine oncology in the past, because it's been very easy to look past those complexities in the past and say, we're just not going to deal with that. The patient will figure it out, right? And it's often very difficult for patients to figure it out in those situations. So it's quite a diverse patient population, and every patient is just a little bit different. I think Rand and I have kind of found over our time of doing this that, although many patients are similar, they're each individual patients and they each have individual challenges. And even several years into the development of the program, every week that goes by, we find something new to kind of improve or change for patients. So it's been really rewarding in that situation.
And completely forgot for me, the involvement of PM&R so that people can get hooked up with rehab or physical therapy or OT or all the things that come afterwards, and how important it is actually to have the nurse navigator you guys were talking about to help walk patients through this, because they already have enough to deal with.
Yeah. And I think, we've been really spoiled within our program at Memorial Hermann. We, of course, have, when you think of the care of spine tumor patients, you think of, radiation oncology, neurosurgery, orthopedic surgery, interventional radiology. Those are really kind of, I would say, the frontline fields that deal with these patients. But there are so many other physicians that are, so important in the care of these patients. And I think we've been really lucky with the Memorial Hermann Tier Institute in having some of the best physical medicine and rehabilitation capabilities, both on the physician side and the staff side in the world, to help care for these patients, often with, quite significant cancer rehabilitation needs.
We're mentioning so many disciplines that are involved in the care, and shocking as it is, taking care of spine tumors is a humbling experience. And so, surgeons and radiation oncologists and interventional radiologists, despite the fact that ego is never a problem, we actually gave up on that. And we keep our ego and we use it elsewhere. And we checked that out at the entrance to the spine tumor board or the spine clinic. And we, again, it is amazing to see how we were able to work together without that hump on our back. And it is difficult. It's proving itself, because once we use all the disciplines and everyone with his own or her own expertise contributes so much to the care of the patients, and then you realize you can't do this by yourself. The days that we always say that the days that you had one giant physician, whether it's surgeon or radiation oncologist or medical oncologist, that took care of everything and was able to save you, those days are gone. I'm not sure they were even ever real true. I mean, the reason we are having such great successes is because we are not using that. We are actually using everybody on the team, and everybody has a lot to contribute.
It's really beautiful what you just said, making sure that we put the patient at the center of everything. I think in this world where things have changed a lot in medicine and we're tugged in a bunch of different directions, and I will mention, RVU models and things like that and putting pressures, but the important thing is the patient. It is always the patient. It is why we got into medicine. And I think for self-sustenance as well as for best treatment, could not have said it better myself. everybody playing together as a team, putting egos aside, and offering different perspectives from different backgrounds of training really does lead to the best, most complete patient care.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Jinwoo Kennebrew.
Thanks again, and see you next time.